All right, and now I'm going to turn things over to Angie LaFlamme to share upcoming SHIP TA and introduce today's speaker. Angie?
Thanks, Andy, and welcome everyone. My name is Angie LaFlamme. I am a program specialist with the center and the task TA team. And before I introduce Amy, I wanted to just share with you all some of the upcoming technical assistance provided by the SHIP TA team over the next few months. So in October, you should have received an email announcing our new allowable investment search tool. Upon conclusion of today's webinar, I'm going to take you to that website and give you just a really quick tutorial about how to use it. It's really user-friendly, and some of you may have been in there playing around already, but if you haven't, we'll take you there and just show you what that looks like briefly. This month, obviously, we have the price transparency guide and this webinar. December, we will have the fiscal year 2021 SHIP NCC templates for you, and then also offer application review and a webinar to go along with that. February, we will be hosting a learning collaborative. In March, we'll have a webinar around telehealth. May, we will look at state innovation projects via a webinar. And August, we will have another webinar around data and evaluation. And then ongoing, we have the COVID SHIP quarterly report templates on our website for you, along with the hospital forms. And then we're just always available for any ad hoc TA, whether it be around the regular SHIP program or the COVID SHIP funds. So feel free to reach out to our TA team at any time with any questions that you may have around SHIP. So with that, I would like to introduce our speaker today. We have Amy Tepp. She's a CPA and partner with Eide Bailly, and she created a price transparency guide for us, and she'll walk us through that today. Amy has more than 30 years experience in healthcare finance, leadership, reimbursement, revenue cycle, and compliance. She's worked as a Medicare auditor, director of reimbursement, revenue integrity, and regulatory review and analysis, compliance officer, and consultant. Amy is the partner in charge of revenue cycle with the healthcare consulting for Eide Bailly. She assists providers by developing solutions focusing on revenue cycle process optimization, charge master development, pricing transparency strategy, compliance program assessment, and compliance audit function. So with that, I'd like to thank you so much for joining us today, Amy, and I will turn it over to you.
So we're going to start with just kind of an overview to set the stage for price transparency, where we're at today. Some of this will also be covered in the guide, but we just thought we'd start with an overview presentation just to get you a little more familiar with what's been going on. I want to say since November 15th of 2019, when this became a lot more involved than what it has been. So we're going to start by talking about the history of price transparency, and also what the final rule that will become effective as of January 1st of 2021. And then some of the approaches and tactics to ensure compliance, which then going into the guide is to help facilities with getting ready for that and kind of keeping it moving and evolving even post 1/1 of 2021. So this isn't anything new. This actually has been around for at least 10 years. We first learned about price transparency through the Public Health Services Act, or the ACA, Affordable Care Act, in 2010, March of 2010 to be exact. And basically, yes.
I'm sorry, Amy, we're not seeing your slides.
Oh, you're not? Okay, I'm sorry. Let me try that again.
There we go.
Now you can see them, correct?
Now we can, yeah. I just want to share with everyone really quickly too, on the right-hand side of your screen towards the top, there is a little word, the word view. If you want to click on that, you can choose speaker view, and then you'll just see Amy and the slides, and you won't see all of the participants. So it's just an easier view for watching the webinar. So thanks, Amy.
Yeah, no, thank you. All right, so basically, this is has been a 10-year evolution, and it started with the Affordable Care Act of March of 2010, where it basically, out of that law, stated that each hospital operating in the U.S. Every year needs to make available and update and make public, in accordance with guidelines developed by the Secretary, a list of the hospital's standard charges for items and services provided by the hospital. And I only read that to you because as we go through everything, that's pretty much the theme of price transparency. You're going to hear a lot of those same terms: standard charges, items and services provided by the hospital. What exactly is the expectation around that? And that the Secretary is to develop guidelines, and that's exactly what happened. So 5 years later, there was not a whole lot of action. I mean, I think facilities and hospital associations work towards putting out there like some top, maybe 20 to 50 Medicare DRG charges for those procedures, like colonoscopies as an example. And the final rule for the inpatient prospective payment system basically spoke to, well, we actually want you to do a little bit something more, specific. So not much, but what they were saying is, we would like you to, at least on your website, post a link. Like if your hospital association has posted this information, just so that it's on the hospital's website to help patients, kind of guide them to where they need to be if they're looking for that kind of information. And then in the 2019 inpatient PPS final rule, that's where we are today. We have, that you're posting your standard charges on your website as a hospital, and that was effective January 1st of 2019. And it needs to be in a machine readable format, no PDF files as an example. It should be updated at least annually, and those facilities that are paid on a prospective payment basis, so not a critical access hospital, they were required to publish a list of prices by MSDRG. And even with those rules, as I work with facilities, I've noticed that I've actually seen PDF files out there, which doesn't comply today. I've noticed that they haven't been updating even the gross charges that they're supposed to be publishing. Now, there's a few other somewhat related things. And the reason I bring these up, and it's mentioned in the guidebook, is because sometimes, CMS has something that's going to be issued soon, and they maybe want to include something in a proposed rule to get some input on that really doesn't, you think, why is that in that rule? And this ONC proposed rule, which deals a lot with that intraoperability with electronic health records, that's what this ONC group agency monitors. They had in a proposed rule where they were requesting comments on requiring pricing info as part of a mandated electronic health information, and they even alluded to potential penalties. And they wanted comments whether they should be including negotiated rates. Should these be made public? And there's been a lot of question around this, do they have the authority to do this at CMS? And I bring this up because as we go through some of these requirements with the price transparency, you see where this came from. So it wasn't in any other rule that maybe when you're looking at, we've got things in the inpatient prospective payment system rules. This kind of came out of a different area that I personally would not normally track. Then in June of last year, the president issued an executive order, and he directed HHS to issue regulations requiring hospitals to post charge information. And he specifically called out charges. He wanted negotiated rates, which is we just heard about in that ONC proposed rule, and shoppable items and services. And then in the 2020 outpatient prospective payment rule, both proposed and now final, there were comments sought on many of the different things that were included in there. And for the most part, those things became implemented as a result of the final rule. And they are the things that we're going to be talking about more here that will become effective January 1st of 2021. One other thing to note, again, somewhat related to price transparency, the 2021 federal fiscal year final rule for inpatient prospective payment system hospitals. Actually, those hospitals, so not critical access hospitals, because critical access hospitals do not get paid on a prospective payment basis. They get paid on their Medicare, 101% of their Medicare cost. But I mention it here because, yet again, here's another thing that Medicare is saying, now we want more information. And what they're going to do is require those hospitals to actually report their Medicare Advantage payment rates and have specific things like a median negotiated charge. You know, it's complicated, and they said they will start this for cost reporting periods ending January 1st of 2021. So for the most part, not till, you know, those ending in 2021. So it's a whole year out there for many facilities. And they're actually going to create a new worksheet in the cost report to capture this data. And the thought is that they will use this data to calculate the rates going forward. And I believe there'll be the rates going forward for those PPS hospitals on starting with federal fiscal year 2024. So moving away from kind of the cost report and cost to charge ratios. So this gets back to the proposed rule and some of the rationale behind why they felt, and you had the executive order, right? That is now having the secretary and directing the Secretary of Health and Human Services to publish and provide guidelines. So that's some of what this was back in August when the proposed rule came out. You know, they've seen a steady increase in the cost of healthcare. We have a lot of patients that have high deductible health plans, so they want to know what it's going to be from an out-of-pocket perspective for them. You know, nearly over half of our states have price transparency requirements, and you know, they just want to have some rules out there and guidelines so that patients can make more informed decisions and increase market competition is what they think will happen as a result, and hopefully drive down the costs of healthcare and make it more affordable. So they believe this will make things more meaningful to inform patients and help them make those decisions. And what they did, and this ended up being codified, put into the code, the federal code, under 45 CFR Part 180, All of the things that I'm going to be speaking about are in that rule, in that Code of Federal Regulations. That's where they will house all of the price transparency rules and guidelines. It's part of the Public Health Services Act, 2718 Section E. And to help with the high deductible health plan, enrollees seek price information. So it's providing definitions, the specific requirements, establishing monitoring and penalties for not complying. So CMS wanted public comments. That's what the final, you get your proposed rule, and it gives everyone an opportunity, be it individuals, be it hospitals, be it hospital associations and other organizations, to provide comments. And they wanted anything, from the definitions to the penalties to the burden and time involved. They were estimating for hospitals to comply with this. They just were concerned again that there's, what they've had out there to date hasn't provided or produced anything really uniform. So every hospital just sort of interpreted, because there wasn't a whole lot of guidance. And so if you go from one website to another for hospitals, maybe you get a whole lot of information on on the charges, and another hospital you're getting a description and a price, So this is hopefully in their minds to close that gap. So where did we land? These are all of the different definitions that now, these headings, if you will, we have definitions now in the code. We didn't have this before. We had the term standard charges out there, and the industry thinks of standard charge as your gross charge off of the charge master. But now we now know what is considered a hospital. We understand that there's now different types of reporting requirements. Standard charges has taken on a new, there's multiple components to what are standard charges. We talk about hospital charges for various items and services, the machine readable file. We've already heard about that. It's been there before. We will learn about these shoppable items and services, public disclosure of non-compliance actions if you don't comply, and any sort of appeals of penalties. So basically, if you're a hospital and licensed as a hospital, you're considered a hospital for this rule. The only ones that are not, if you're like a federally owned facility, a part of an Indian health program, they are not part of this rule because their information is considered to be public anyway. What this basically is clarifying, if you're in any one of the 50 states, any one of the commonwealths, or any territory, this rule, this is the definition that applies to you, and you're licensed as a hospital. And then I noted the citation, again, it's part of the Code of Federal Regulations now. And one thing that they did recognize is that some of the small hospitals and rural hospitals, including CAUSE, they will face challenges in implementing these requirements. But they at CMS didn't believe that this was going to be very challenging or hard to accomplish. I just put that in there, and this came right out of the final rule as a CMS comment, just to put things in perspective. I think as you work with hospitals, you understand they have a lot of challenges, and we had a whole lot of interesting things with COVID and whatnot that I don't know how, if this is really a fair statement necessarily, but that's the, just giving you the mindset of the final rule. These are the different things about what is a standard charge. And again, when we get to the guide piece of this presentation, you will see the same information is in the guide. We have, gross charge is the thing right out of the charge master. We're going to learn about negotiated payer-specific charges or rates, and it's confusing because we've spent years trying to make sure that when we use the word charge, it meant the gross charge, and that when we say a rate, we're talking payment. Well, they're using rate and charge in the same sentence sometimes, and that can be kind of confusing. But the negotiated payer-specific charges are actually the payment rates that hospitals contract with, say like a Blue Cross and a Medicare Advantage or a Medicaid managed care organization. Those are all generally contracted rates, and those are things that are now being required to be disclosed. They also need to provide their cash discounted price of what they would provide under their policy which generally is like a percentage of charge off of the charges. So hopefully that would help those with high deductible health plans and health savings accounts to have that information available. And then after you get all of that information put together, you have to go across all those different types of charges for all of the different components and come up with what is the de-identified minimum negotiated charge and the de-identified maximum charge. And that's just exactly what they are. It would just be across all of those negotiated rates. This is the minimum payment, and this is the maximum payment for that particular charge item. Basically, the CMS doesn't feel that these things should be that hard to get. That might be the case at a large hospital that has a contracting department and a contract management system. Now, a lot of the critical access hospitals, it's maybe not as hard to get either, because a lot of these organizations are paid on a percentage of charge basis. But some have some other complicated payments, which arrangements with health plans. Again, this, just like it has been for the last few years, this needs to be updated at least annually. You should make sure you put the data in there so that somebody looking at it can tell the last time it was updated, and that you have a machine readable format, which is out there before, but they've added a few more clarifying things to this. The file format's been the same. It's something that what they added here is that you can't bury it somewhere in the hospital's website. It needs to be easily searchable with some standard naming convention. You cannot ask for personal identifying information or having people create a login. It should just be readily available for patients to be able to look at. Now, all of what I've just talked about is required of every facility. Every facility needs to post this machine readable file. The second requirement is shoppable items and services, and that can be provided either by posting something on their website or having an arrangement with a vendor who can have what they call a price estimator available on the website of the hospital. A lot of confusion's been out there. Sometimes people think, oh, I've got my price estimator. I've got an arrangement with a vendor to do that for me. They still need to put that machine readable file. And we've had people call us and say, so I'm good, right? If I have the price estimator. Yeah, you're good for that piece, but not for the machine readable file. So they still have to provide both. And so basically what a shoppable item and services is, it's something that it's not elective necessarily, but it's something that it's not emergent. It's something that I'm going to schedule in advance. I always go back to the colonoscopy thing, or I'm going to have my gallbladder removed. It wasn't an emergency situation. I need to go see a doctor. What's an office visit going to run me? So those are the types of things that are what we call a shoppable item and service. CMS has provided 70 required ones. If you don't provide, or the hospital doesn't provide all 70 of those, they just have to report it and then say we don't provide this, not provided here. However, you need to come up with a total of 300. So say you provide all the 70 that CMS has required, you need to then come up with another 230 to post. If you only provide 50 CMS, well, then you'd have to come up with 250 additional ones to come up with the 300. And I just mentioned where that came from, the number of 300, and that was some study that was done back in 2011. You need to report all those same things I talked about with the gross charge, the specific negotiated charges for each one of those health plans, discounted cash price and all that, the de-identified minimum and maximum, the location where the service is provided, and the CPT code or HCPCS code that's associated with that. And it needs to have a plain language descriptor. And again, this needs to be provided without charging people to get that information, or for them to provide any sort of special login with personal identifying information. And this was the price estimator. So if they decide that they're going to use a vendor, they are able to do that and meet that requirement as long as it's providing the 70 required CMS, as well as the additional 230 to get to our 300. And that will actually provide an estimate for the consumer of what they will have to pay the hospital for that service. I just put on the side kind of what CMS was saying, that they thought this would average facility is $12,500. Having conversations with facilities, I think it's a tad bit higher than that to have one of those vendor tools available. And all of the shoppable items and services, you'll see we have all that provided in the guidebook. Something that was not finalized but was in the proposed rule was they were going to ask hospitals to potentially have a hard copy booklet of all this information. I just put it out there because sometimes stuff comes back again in another rule. So it's out there. I don't know if they'll ever go back to that, but I hope not. And then we do now have civil monetary penalties. There's a $300 maximum daily penalty. You get a written notice of non-compliance. Supposedly, I think they're going to have some sort of audit around this piece. And you'll have an opportunity, or the hospital will, to do a corrective action plan. If you fail to do these things, that's when the penalty kicks in. And then there's also this email address that you can report facilities that don't appear to be complying with the price transparency requirements. And again, just some information on the burden right out of the proposed final rule, I should say, of what they kind of upped their estimates in the final rule. Like they were not at least recognized that it's going to be a little bit more involved than what they thought. And, hospitals have been dealing with all the stuff around COVID. They've had various waivers. I think I just saw something on the FAQs. I want to say it's like a 154-page document as it relates to all of the things around COVID from the day we started and CMS started issuing waivers and things. Telehealth has gotten a lot more involved with facilities and all these different things that facilities have had to think about and focus on. And so this was the hottest thing out there up until the middle of March. You know, we had it issued in November, and facilities were like trying to understand what this was going to mean. And then COVID hit, and you know, obviously there was a lot more other things that facilities were dealing with, and it sort of kind of fell away, you know, kind of to the side. I just mentioned a couple things here for hospitals to understand. This is not, in the guidebook, I don't believe, but you know, if they signed up for any of that relief funding, they signed off on some terms and conditions where one thing was that they would not surprise bill a patient. So that's something that they need to make sure that they are complying with, that term and condition. That's basically, when you hear surprise billing, that's talking about out-of-network billing. So if I have a procedure done and I go to my hospital, they're in the network. Well, there was maybe an anesthesiologist or CRNA who did part of my care during the procedure, and I find out they're not part of my network. Well, how was I supposed to know that? And then I get a bill that basically says you owe this, you're out of network, which is usually higher, right, of a out-of-pocket expense. The other piece is if any of the hospitals have done anything and filed through that uninsured claims portal, they are not able to balance bill for the difference between what they got paid, and this would have been self-pay patients, and what they got paid and what the charges were. They have to accept the payment in full. And these have civil monetary penalties associated with them as well. Another helpful thing that came out, and this is referenced in the guidebook, a few weeks ago, actually, CMS now has a web landing page for hospital price transparency. There's something that speaks to the hospitals and then speaks to the consumer. It provides a compliance checklist for hospitals to kind of look at and kind of go through, which could be an enhancement or other thing that they can utilize when looking at this guidebook as well. There's some FAQs and talks about machine readable file and the shoppable services. And I just bring this up because this is all about a federal requirement, but many states in the last few years have had state mandated transparency requirements. And so that's something that should not be forgotten about. It needs to be incorporated as well. So I'm just going to pause here if there were any questions at this point. Otherwise, we'll walk right into the guidebook. I don't see any. So let me stop sharing that. So hopefully, if you aren't seeing the price transparency guidebook, let me know. But I'm just going to kind of scroll through this, and hopefully you won't get motion sick. I want to give credit to Sue Rail, who's a manager who works with me in our revenue cycle team. Sue is the one who came up with the, as I mentioned, the 230 additional potential shoppable services, which is in one of the appendices at the end of the guidebook. So, you know, we have our, basically the table of contents. There's a couple of sections here. You know, the first one, basics and history of price transparency. I've just gone over all that with you, but this is more detail if that's something that you want to spend a little bit more time looking at. You can look at those same things, but I've talked about all these different rules and related rules. And then the price transparency, the final rule. Section 2, again, is going into those definitions. I've already covered that with you as far as what's a hospital and, you know, the exemptions from this, what are standard charges. And then section 3 is really something that I want to focus on as part of this piece of the discussion. Hospital readiness, and what is it that hospitals, if they haven't started, and I'll tell you there's a fair amount I know of that haven't maybe started much, or they're just kind of done parts of it. This is to help them kind of formulate a strategy, to keep it out there, and formulate a team of people that will work on this in the future. It's not a one and done. And we'll get to that. I'll go right to that section. We do also have this where you can just click on the, you know, have a quick link to the rule and the law if that's something that you're interested in. Okay, here's section 3. So the first thing that we talk about is establishing a team. And I know some of this stuff, it sounds like, you know, well, that's just kind of common sense. But especially in the smaller hospitals, because people wear so many different hats, I think like, and I'm not, as I always say when I meet with these facilities, I'm not saying let's set up another meeting on the calendar. If you already have a forum that's you've got going of a meeting, if you have a revenue cycle group or something where this might fit in, that's fine. But I still feel like it should be something more formal so that they have some sort of governance, there's some sort of work plan associated with this to make sure things are happening. And so it would be, do we have who within the organization is going to be the group of people that are part of this team? Who do we need are the stakeholders and, you know, to get this project going? You need IT, you need somebody who understands the contracts. You have to have somebody who maybe is over the pricing for the facility and how those prices get set up for new services. And maybe it's the CFO who's the executive sponsor. They maybe aren't the main project leader or manager. If the facility has somebody who maybe works in the charge master area, maybe that person could be kind of the project manager. It just depends. Some people have great skills at doing that, and others maybe that's not their thing. But that's basically what that first step is. And then we want you to populate a work plan. And I've provided just a very simple Excel document that I think is, I've used it before. It's not like, it's not Microsoft Project. You know, it's not that all that project management involved. It's just an Excel thing that we have provided. It should be on your website, so that's something they can download and actually use for this and any other purpose that might be helpful. It actually calculates, what I like is by the dates that you put in the spreadsheet, you'll see that it'll tell you if something's going good, green, or if it's red, we got a problem, or yellow is that we're coming up against a deadline. So some of the things for them to consider on the work plan. Now, right now, maybe it's not the time to have a charge master review, but I still would, I would encourage them to have that as something to look at because if they haven't had an assessment done of their charge master in more than 3 to 4 years, it's probably time for a charge master review. If you have if your charge master is not accurate, you probably have some problems with what you're posting on the website ultimately. And there's probably a lot of things that could be done to help with this transparency. You know, we talk about bundling of things, bundling of supplies, rather than charging for some things just individually, which helps make the charge master less lines and, you know, less room for error. So that's one thing. The charge master updates. This every fall. In fact, in the next week or so, they're probably going. The AMA has their CPT symposium, and that's telling you about what the CPT code changes are. You know, who's responsible for that at the facility, and how are we going to make sure those changes get updated in the pricing file that we post on the website. This adds a little different dimension when we're trying to post something for 1/1 and we know there's changes coming up right at the beginning of the year. Also, what is the hospital's charge and or pricing strategy, and do they have a policy? If they don't, this would be the time to have something like that put together. The strategy is about, do we, you know, are we using cost plus a markup? Are we just looking at peer data, you know, market data from our peer facilities? Or are we making sure that we set our price at above the net highest payment rate we have? That should just, if you have it in here, you should be able to put it in a written document. And what I just spoke to is also looking at, you know, we have our prices in line with that strategy. So that's something that they should be considering. Looking at the information systems, you know, the machine readable format that we have currently, is that going to work in the future? The strategy for this extraction of the data from the system. How are we going to set up the machine readable or searchable capabilities? Who's in charge of updating the website? And is it able to be exported? That's one of the requirements. And how do we get that to work from our website? And just where does it make sense to have this so that we're meeting the requirements of having it not buried somewhere in our website? Maybe we've already taken care of that and it's not an issue, but that's something to consider and track. The contracts, do we know who we're contracting, have contracts with? A lot of times I'll hear from facilities, especially when there's been some turnover, somebody new comes in and they're like, I don't even have any idea what I have contracts and who I have contracts with. That might be an opportunity to actually find a central repository and understand who's responsible for having those and keeping them updated. And do we have rate schedules? Do we understand how we get paid? Those types of things. And this payer matrix, this is something that sometimes we suggest out of a rev cycle assessment. And this should just have some basic information. If they don't have something like this, this is something they should strive to create. But it's for every health plan that they contract with and bill to, understanding, you know, who the contacts are there, how we get paid, do we bill on a UB or a 1500? And then also the other thing is, what's going to be the source of truth for these different charges that we have to provide on this document now? Do we have state requirements? How are we going to go about with the shoppable services? Are we going to do a price estimator? Or are we going to just get enough of the data and just post something on our website? And then the next piece is the implementation of your plan. And I look at this as an ever-evolving thing. A lot of hospitals kind of forgot about transparency, obviously, during the COVID pandemic. There was some litigation out there, and I think hospitals were hoping that that might have been something that would have been in favor of the hospitals. And in the middle of the summer, we found out it was not looking so good in that event. And that's when it kind of came to everybody's, oh, wow, we still have to do all this. And so a lot of people are kind of late to the game. This guidebook's a little bit late, but I still think it's something that they can use as a guide to help ensure they're on track, you know, maybe with what they're doing currently. Are they hitting the mark? Or is it something that there's some things maybe they didn't consider? And it's better to have some sort of a plan. And if you're gradually implementing things, than to have somebody say, well, they haven't done anything on price transparency. You know, just to have something documented as your process. I've already talked about these civil monetary penalties, and then lots of great resources here. You know, we have the price transparency fact sheet from CMS. There was a webinar that CMS put on back in last December. So all of those things are referenced here. We have the things that link you back to the hospital pricing transparency webpage. And then this is something that was also often something provided by CMS as a sample of how to display the shoppable services. If you're not going to use a price estimator, this is one example of how CMS, maybe for a colonoscopy, you know, these are the different typical things of items and services that would go into a colonoscopy. You'd have your primary diagnostic procedure, anesthesia, which is with just the medication portion of that, any physician services, if you employ the physician or the professional, like a CRNA, those charges would have to be reported here. These were not provided by the hospital in this example, so they don't, because they are billed by an independent professional. You know, facility fees and so on. And then you see this office visit one. I mentioned that before. And then Appendix B, these are the 70 shoppable services that CMS has as required. And like some of these things, psychotherapy, maybe they don't do psychotherapy. Those might be some examples of E&M services that are not provided at a specific critical access hospital. They would note that as such and move on and have to kind of backfill it with another thing. For a couple examples, other things. What you see here, for the most part, these are CPT codes. But this, if there's an asterisk, this is actually a DRG. So that you'd have to go to what's included and all that with a DRG type service, even though they're not paid on DRGs at a critical access hospital. That's what that asterisk represents here. Here's that list of additional 230 or so added examples, just as a guide to help facilities identify what are some other things that I could include. You know, at least it gives them some sort of a guide to populate that piece. I provided here a sample charter template. I know a lot of facilities, larger organizations use these a lot. It's more so to kind of, you know, I'm not just going to have a group of people get together. We need to have some common purpose. Who's the sponsor of this? Who are the members of the committee? And what is the duties and the responsibilities of that membership? And what sorts of reporting and communications and who to should we do that? And how often are we going to meet? It's just to give them more of a purpose for meeting. This is that sample work plan, and it's hard to read here. I really encourage the facilities to get that off of the website in the Excel format. And I just high level provided, you put, the current date goes in at the top here, and that then drives how these column G gets populated. And, I just started with, as an example, the first thing, price transparency work group. Populate the work plan is the first task. There's going to probably be multiple tasks associated with some of these things, and just kind of how this thing works. And the last thing that we provided is something that CMS had put together as a what an example of the machine readable file would look like, with the sample display of gross charges. And this is for infusion and hydration services, as well as room charges. And you can see you have the CPT codes, NDC codes for drugs, and we have the outpatient gross charge, we have inpatient and ER charges, and then the emergency room drug charges. So, and this does apply to all of the charges. A lot of facilities, the pharmacy charge master itself is, there's so many drugs out there. It's a huge file. So to be able to extract all of those pieces and get them in something that's not too overwhelming for people to look at and post on the website is the challenge, is one of the many challenges, obviously. So with that, there's some other references at the back here. I don't know if there's any questions or something I didn't cover.
Hey, Amy, this is Angie. We had a question in the chat box. Dorothy was wondering if you could please review the surprise billing again.
Oh, sure. Okay, so surprise billing, and this is something that actually has been out there. Everybody thought that would be something that would come about as opposed to this price transparency stuff. What surprise billing is, and it's a bipartisan issue of concern, is out of network. So if if you look at your health insurance and if I go to these providers, it's considered in my network, but if I go to somebody not listed in my network, I have to pay more out of my pocket. I'll have more deductible potentially and more co-insurance. So with COVID, they have kind of, if you're in for COVID, you cannot charge a patient that extra amount because they potentially maybe had gone to somebody who wasn't in their network. So you're prohibited if you have received any of that relief funding and you signed that terms and conditions provision. That's the only thing I caution people about. I mean, I'll use an example of somebody, I know of a situation, their relative went to the local critical access hospital. The nearest larger facility was full, couldn't take them. They had to airlift them to another neighboring, community, which was maybe within 4 hours. I mean, who knows if those, if that facility was within the network of that patient, they could potentially have some of that out of network stuff. So you're prohibited from billing for that difference.
Thanks, Amy. Is there any other questions? Please feel free to type them in the chat box, or you can unmute yourself and ask that way as well. All right, not seeing anything or hearing anything. I am going to share my screen now. Let's see.
Should I stop sharing mine?
Yeah, maybe.
Yeah.
Let's see. Okay, I'm going to share my screen now. and take you to the allowable investment search tool. So can everyone see the tool? Can you see that, Amy?
Yep.
Okay. All right. So last week, you all should have received an email announcing the new allowable investments search tool. And this is just another way to enable SHIP grantees to be able to search for allowable investments under the 3 categories of value-based purchasing, accountable care organizations, and then the payment bundling, prospective payment system. And actually, I should go back. Maybe I'll quickly just go back. Oh, it's not going to let me. Why is my not going to let me go back? This is located on the SHIP website. There is a link to it on the landing page of the SHIP website, or in the navigation blue bar on the right-hand side of the screen under allowable investments. There's allowable investments search tool, and that will bring you to this page. And here is where you can insert any keywords to what you are trying to determine whether or not something is allowable, unallowable, or it may require prior PO approval. So you can search here with some keywords. You can filter. Actually, let me go back a second. You can enter something like swing bid, finance. These are previous searches that I've done. And then once you enter a search word, you can hit apply, and your results will show that way. If you want to filter it further, you can choose a keyword and then choose whether or not you want to know if it's allowable, unallowable, or if it's going to require PO approval. You can filter it even further by choosing one of the investment categories. So just as an example, I'm going to type in travel. Say that I want to know whether or not some of my hospital staff, if the SHIP funds would cover travel for hospital staff for maybe for training purposes. So I would type in travel. If I didn't want to filter it down anymore, I could just hit apply. And this is what comes up: travel expenses for hospitals, unallowable. And then it gives you a little description below it. Expenses incurred by hospital staff to travel to meetings or training, such as mileage, food, per diem, and so forth, is not an allowable investment. So that's an example. Had I chosen travel and allowable and hit apply, there are no results, which means that it would not, if you were using the word travel in the sense of wanting to know if hospital staff travel was allowed, that would come up as nothing would show that it was allowable. Another sample, let's say we want to know about, since we're doing a price transparency, let's say price transparency training. We would click apply, and I left the word allowable in there, and the check mark shows price transparency training is allowable. And then it gives you a little couple sentence or two explaining a little bit in more detail about why that activity would be allowable. You can also oftentimes when your search results come up, you will have in the lower right hand corner here expand for additional resources, and you can click on that, and here it's taking you to a webinar that was done January 2019 around this topic. I'm going to do one more search for you. Let's do staff salary, and I'm going to get rid of, I'm going to reset here to get rid of any filters that I have here. Staff salary, it's coming up no search results, which means that it's probably not allowable. If I clicked unallowable and staff salary, Oh, you know what? Let's just try one. I wonder why that one's not coming up.
Angie, this is Sally Buck.
Yeah.
Hi, everyone. As you're doing the search, Jerry had put a question in the chat box about SHIP funds for price transparency. And with the NCC update on the allowable investments work or table, that yes, software or hardware for pricing transparency would be allowable, as well as training. Sherry.
Great, thank you for that.
Okay, well, we should move to the TA updates.
Yeah, so
Great.
I am going to stop sharing and I'm going to turn it back to Andy.
All right, thank you, Angie. So thanks everyone. Thanks Amy for the presentation. And just before everyone leaves, I would just pull up these polling questions. Just the same question from before, and as well as a few additional ones. So if you wouldn't mind filling this out before you leave, that'd be great. I posted links to the resources in the chat box, and we'll send this and the recording out within 5 business days. But once again, thanks everyone for attending today. Thank you to all our speakers, and thanks again for filling out this poll. And have a good day, everyone.